it now? Okay, wonderful. So good morning, everyone. It is still morning, right? 11:35 in the morning. This is our first session. This is the Health and Government Operations Committee. I'm Jocelyn Peña-Milnick, the chair, with my amazing committee here. We have a couple bills on the agenda, and it's our first voting session, this session 2025. We are going to start with House Bill 536, Delegate Gazzoni, Education and Health Emergency Use EPEN alterations. It is a withdrawal of the bill. Is there anyone against the withdrawing of this bill? No. It's been moved. It's been second. All those in favor say aye. Aye. Any concerns or objection? Seeing none, it's been withdrawn. Let's go on to House Bill 170. It is a departmental bill, Health, Maternal and Child Health Population Health Improvement Fund. It came out of subcommittee favorable, and the analyst is Aaron. Aaron.
This is a departmental bill that extends from December 31st, 2025 to December 31st, 2027, the date through which the Maternal and Child Health Population Improvement Fund may be used for maternal and child health population health improvements. The bill will allow the Maryland Department of Health to spend through calendar 2027 any monies that are remaining in the fund on December 31st, 2025.
Chair Bagnall.
Thank you, Madam Chair. We had a great discussion on this. It is just moving a date to allow us to draw down on existing funds, which are currently supporting an array of programs created by this committee to address maternal mortality and morbidity outcomes. We had a robust discussion, and I did share the 2023 report with the committee. We're still waiting on the final approvals of the 2024, but because we did have some outstanding questions, it passed not unanimously because we just wanted to get a snapshot of what we had. So I asked from the department, and if you will indulge me, I'm going to read out some of the information.
If you can read out the programs and what counties, and
Absolutely.
Again, it's existing fund, no new funds.
It's existing funds, These are multiple programs that are across all counties, depending on the specific program, but the dollars are flowing across the state of Maryland. There's the perinatal home visiting, which is in-home services for pregnant individuals and children up to the age of 3. It's provided by trained professionals or nurses focusing on patient education and support during and after pregnancy. 16 home visiting providers serving 14 of Maryland's 24 jurisdictions. In 2023, 5,412 services were provided to 627 participants, 63% in rural communities. None of the participants experienced birth complications. And the doula services, as this committee knows, a doula, a birth worker, they're trained professionals who provide physical, emotional, and informational support to birthing parents. Among the participants, 68% were Black. None experienced birth complications. Centering pregnancy it's a cohort model with about 8 to 10 participants in the cohort. It's for pregnant individuals. It's building relationships, health literacy amongst the participants. This prenatal program went from 4 sites in 2021 to 17 sites in 8 counties by 2023. 82% of the participants were Black or Hispanic. This was a priority of the Black Caucus to address the health disparities in our Black and Brown communities for maternal mortality and morbidity, and none of the participants experienced birth complications. The MOM program is enhanced case management services to address health and health-related social needs, well-being, treatment, and recovery for pregnant and postpartum participants who are managing an opioid use disorder. None of the participants had experienced birth complications. And the last program is the Healthy Steps, and that is, again, where centering pregnancy is an educational program for pregnant individuals. This is for individuals who have babies 0 to 3. It's Child development experts join the pediatric primary care team to ensure universal screening, provide successful interventions, referrals, and follow-up to the whole family. And 1,370 infants and toddlers were serviced in 2023, 85% of whom were Black, promoting positive parenting and healthy child development outcomes. And we also have, of course, the asthma program, which is a part of that fund as well.
Thank you very much.
And with that, I would ask to move the bill.
Thank you so much. There's a second. Are there any questions? Delegate Kaiser.
Thank you, Madam Chair. I have a question for the subcommittee chair. I'm understanding that we're just extending a date and we're just drawing down funds. It sounds like from what you described and what you read to us, that these funds have been immensely successful with maternal and newborn care. So what are we to think in 2 years from now? What are we going to do for families in these same areas of need?
That's a great question, but it's not answered by this bill. This bill just addresses the existing funds. So, when the funds run out, we'll have to reassess, do a cost benefit analysis and decide what we want to do from there. But this is not predictive. This is just drawing down the existing funds to support the good work of the programs.
Delegate Chisholm.
Chair.
My pleasure.
And this was in my subcommittee and I asked several questions. I just wanted to make sure I'm still certain on it.
Absolutely.
So we had $40 million. As at the end of fiscal year 2025, we're going to have $24 million. And this bill seeks to make sure that those remaining $24 million can be applied to the programs you just mentioned. If we don't do anything, it seemed like somewhere I saw in the bill, they almost have to accelerate that spending really quickly. Is that correct? Or what would happen with the $24 million at that point?
Essentially, it's because it's a special fund. We not only would we not be able to draw down any of the federal match dollars, but we would simply lose that funding to be applied to these programs.
But in essence, that money is currently there right now. Is that correct?
Yes, there's 24.1 million. The reason that the department sort of put a caveat on if it would still be 24.1 at the end of 2025 is because they're actively supporting these programs. So it may be a little less, but they've been very efficiently partnering with our nonprofits. So when we created this fund, which was 40 million, that it took some time to staff up and scale up, but they believe that this remaining time will allow them to expend the existing funds.
What happens when we get through all these funds? Is it going to be one of these mandates that we continue to have to fund?
It is not a mandate.
Okay.
Not a mandate.
It is not a mandate.
Thank you, Madam Chair.
You're welcome, and thank you for the questions. Delegate Shalega, and then followed by Delegate Hill and Hutchinson.
Thank you. So the fiscal note says on page 3, absence of the bill, any unspent funds remain in the fund, and MDH would require general funds to continue. If it's not a mandate, why would they have to spend general funds? And the other question would be, why aren't the MCOs doing this? I think we've been committed to maternal morbidity, helping, pregnant moms, newborns. This committee's been very focused on this, but why aren't the MCOs doing this?
If I may, for your first question, it is not a mandate. It is worded if it chooses to continue, which means that we as a body have to make that decision, come back, right? It's not a mandate. And I will then allow Delegate Bagno to answer the MCO question, and I can help as well when you're done.
This was again a program that was established by this committee in response to the recommendations from the Maternal Morbidity and Mortality Review Commission, and these were evidence-based programs that that utilize Medicaid or utilize this special fund to leverage our relationships with nonprofits. So it's not, it's a special fund that was created specifically with the hospitals to also address the rate of outcomes that were coming through our hospital system to address healthcare deserts.
But in addition to that, we often have a lot of waivers, 1115 waivers, 1332 waivers, in order for us to try innovative things, right? So this was an opportunity because we know that the maternal mortality rate is very high, especially in certain communities. And this was an opportunity to partner with the federal government to be able to do that. So they gave us matching funds. And the hospitals did a one-time assessment because they saw that it was important. Many of these communities end up in the hospital without insurance. They don't have access. And they saw that it was an important program to do. So why was it done? Because we were able to get money from the federal government. It was only a one-time assessment. We need to move the date so that we could use what's there. It is no new money. It is not a mandate. We will have to come back to this body for this body to make that decision. The program has worked really well since it started. And what I love about it is that it is throughout all 24 jurisdictions, which is so important for us to address that. Maryland went from a D to a C right now. We finally went down from 25 to 19 in maternal mortality. Our numbers are not good. And we have done a lot as a body in this committee. I sent a memo this past summer that a lot of you got with everything that this committee has done. And I know that Delegate White Holland has now taken, this is her baby, taken it on as well, which I am so glad. So it is an issue that, the MCOs are doing their best, but it's not enough. They don't have enough resources. And this was an opportunity for us to get funds to be able to address an issue that we have.
Yeah, I understand the programs. I think I voted for the setting up of it, but have to say I'm very disappointed that they couldn't get their act together and use the money in the amount of time we gave them to use it. So I'm not sure where I'm going to vote on this bill, but it's not because I don't support the programs, but I question the ability of these organizations to deliver services in a timely amount.
So if I may, and thank you, Delegate Shalega, I appreciate your comments, but I do want to address that it wasn't that they couldn't get their act together. So let's get the facts from Delegate Bagno why it happened, because they work really hard. Go ahead, Delegate Bagno. And I appreciate you bringing it up, always.
Thank you very much, Madam Chair, and thank you for the opportunity to address that, because I don't want there to be an impression that this was a failure on the part of the health department. It was quite the opposite. We were ramping up this program in the midst of COVID, which caused some delays, but also these were evidence-based programs that they were utilizing to ramp up, and in fact, they did such an efficient job that we didn't spend down the funds at the rate that we thought we were going to. So we actually have more remaining funds so that we can actually sustain these programs for a longer length of time. But we need to give the time because it's in statute, because otherwise we will lose access to these funds. So it's actually a very positive story of the department doing their due diligence, partnering with organizations that do this, ensuring that they had equity across the state, and being very efficient in that effort. So I think that you will feel good about this vote because it's doing a lot of good work, and it's leveraging those dollars in a very effective and meaningful way.
And if I may add, it had an artificial date. We didn't know COVID was happening. And as you know, the Department of Health was so busy during COVID, and it was overwhelmed, right? So many things went wrong, and we all tried to chip in and help, and that was part of it. But, we don't have COVID anymore. We're not in a state of emergency. They know it works. and they're able to do it, and they have the partnerships. And as you know, developing partnerships takes time, right? To make sure you cross your T's and dot your I's as well. And look, it's working, and it's all over the state as well. And it's an issue that this committee is tackling, like how can we go down from 19 to, I love to be like top 5, you know? What else can we do? And I ask myself that often, what else can we do? What else can we do to bring it down from 19 to 5, you know?
Going forward, I share the concerns that Delegate Kaiser brought up, that, you know, we'll be back here with another request for more funding. Aren't the MCOs paid in a per capita basis for the patients that they care for?
They get paid, and as
And
you
it-
know, there is a state commission that meets. I used to be part of it. I know I forget who's on it, the Medicaid Commission, and they have a lot of new requirements. The Secretary of Health, this new Secretary of Health, Dr. Laura Herrera Scott, has a lot of new requirements for the MCOs, and so that they can meet. Some are amazing, but some do not do as well. So now they have a lot of different criteria and tests that they have to meet. So I'm hoping that improves. Again, that is not the bill we have today. Today, we just want to allow them to continue to do this great work, to help us go down from 19 to a great number, and to make sure that our women throughout all 24, our 24 jurisdictions are delivering these babies, right? And that they're healthy, both the mom and the child.
Agree on that, Madam
Yeah.
Chair. I don't think there's a person in this room that
Yeah.
wouldn't feel the same way you do.
Yeah.
But I would, again, reiterate that if these are Medicaid patients, then the Medicaid MCOs should be delivering these services. They should be caring for pregnant women. That's what we're paying them to do. And more importantly, that's the health care charge that we've given them. So, going forward, we need to make sure that MCOs are committed to caring for pregnant women and caring for newborns, and not counting on us to come in and, do their job for them.
Yeah. Now, I understand it's a valid concern, but you know what? As you were talking, I was thinking of how, for example, I have a bill that I'm not putting in this session that will require the MCOs to reimburse for the community health workers, right? We all know that community health workers are key to help our communities. But if I give them that task, they cannot do it financially, right? Because it is a $28 million tag. So I'm not putting in the bill. So yes, it's their job, but all these different tasks they have to do adds up, right? And we sort of, we battle with, do we require it, not require it? Do they have to raise the rates? How much does that cost? So it's all, I take, well taken. I respect what you're saying, and you're right. But it is really a struggle when we look at these fiscal notes and we're trying to make decisions, and that's why we kind of try to go out of that four walls and try to be creative with programs like this. But I appreciate your comments. Okay, you're welcome, Delegate Hill, and then Hutchinson, and then Delegate Bandari.
Thank you, and I appreciate. And I guess I'm asking for indulgence. I thought I had maybe 2 questions. Now I've got more.
Are we surprised?
I just want to be.
We're gonna get a sign.
Okay. I just want to make sure I'm clear.
That sounds good.
Okay. $40 million is what we started with, an assessment, some matching funds, the other. We used evidence-based programs, rolled them out to see if we could affect positive change in this population. You have a report that indeed, in the first few years, we've already seen positive improvement. So the first question is, if it has not already been, will you share, make sure that all of us get a copy of that letter?
Yes, and as I actually made a call to the health department yesterday. I made multiple calls to the health department yesterday, try and get this information. And they're still in the final review process of 2024. So what they shared with me was a snapshot of what's
Okay.
coming from that.
So when we get the we'll
from
get
that
the-
report, and they'll share it. I'll share it with the entire
Excellent.
committee.
And hopefully, and if not, it would be nice to know in that final evaluation if they're also looking at over several years, how many repeat families, because we want to see, I think, when we're looking at outcomes, not just that we've improved maternal and fetal mortality by lowering those rates and outcomes, but that the care overall is getting better, that people are understanding better, that the providers are understanding what they have to do better. So that would be interesting to see. Number two, Delegate Shalega asked about the MCOs, and I had a couple of questions. I thought that when we add mandates under the ACA, we have to pick up those costs. So I just need some clarity. If we said to the MCOs, you now have to provide these home visits and other programs that are happening under the MCO, you have to provide it directly. Does that cost come out of their capitation, or do we have to pick that up as a mandate that we're now giving them?
I don't know the answer, but we can find that answer.
Okay.
The bottom line is that it's going to cost something.
It's going to cost.
Yes,
And I don't think
that's
that
the
the
bottom line.
MCAs, because my understanding is that the way the MCOs work, they're capitated, and their profits come out of what they call care management, but what most of us realize is often just care denial. What is nice about this program is as we're already seeing outcomes, then we know that these are actually high-value programs. And to that extent, we've now done proof of concept here in Maryland, and it may well be that we can then demonstrate to the MCOs that instituting those kinds of programs would actually lead to improved profit margins because of improved outcomes and lower costs to them on the back end. But short of their going, hey, this is another way for us to improve our margins and make more profit, I believe that it's going to cost us to mandate that they do it, but it would be good to have that information. And then I guess the other thing I wanted to be clear on is that even with this extension, the question is what happens when the funds are depleted. That's not what this bill is about, as has been stated. But all the other ideas that are being discussed, like asking the MCOs to pick it up, or suggesting that the MCOs could actually be profitable if they voluntarily pick it up, that all comes out of the program. And when we get another 1.5 to 2 years of seeing effectiveness, we not only have healthier patients, healthier babies, but we have more evidence that these are the kinds of programs that every healthcare provider, every insurer, whether an MCO or independent, should want to do because it works, and when it works, it saves them money, which is often their bottom line over outcomes. So is that your understanding of what we're trying to do here?
And I think you've articulated it beautifully. And again, the reason that we still have money remaining to spend is to the point that you've articulated.
Thank you.
And thank you for explaining it so clearly, because the reason why we do these waivers is the states, the federal government gives us, CMS, the flexibility to try these programs to show whether they work or not. And then if we can show that they work, then you discuss where the money comes. Is it worth the investment? And they have the next 2 years, Delegate Hill, as you stated, to decide that, right? And they probably will pick it up on their own because they will save money at the end, right? As well. And those waivers are really wonderful. It's a great way for the states to do innovative things and think outside the box. Delegate Hutchinson, thank you.
Thank you, Madam Chair. I actually don't understand the last sentence in the fiscal note where it says, in absence of the bill, any unspent funds will remain in the fund. So what happens to the $24.1 million if we don't do anything here?
Can you, yeah, we will find the answer, okay? I think I know. Okay. Delegate Kaiser, and then Delegate Hill.
Just quickly, my understanding is at a certain point in time, the Appropriations Committee looks at the different funds that have like remained steady for a period of time that aren't being spent and bring it back to the general fund. But that doesn't happen necessarily on an annual basis, is my understanding, so.
And Delegate Hill?
Yeah, what I was going to add to that is, these are dedicated funds. They can't be shifted. So if they're not spent, they sit there until we, as Delegate Kaiser said, until we decide what to do it. To Delegate Shalega's point, where it then goes on to say, and we would have to, if what is missing there is if we decided the programs need to continue, then we would have to. That's what I think the fiscal note is saying. We would have to find another way to finance it. So if this bill doesn't pass and we want the programs to continue, we cannot use the funds, and we'll have to find other resources to fund the programs, or they shut down, and we go back to the situation which we were in before we passed the original bill.
And
Thank
we
you.
were told that if this bill does not pass, the program ends December 31st, 2025. That's right. Yeah.
Thank you.
You're welcome. Delegate Bandari.
Thank you, Madam Chair. I think these are the very valid questions to Delegate Hill. You raise why MCOs. I believe these are the specialized service and expertise program, like the services outlined in the bill, like home visiting, doula services, and program like Healthy Steps and Centering Pregnancy. They require very specialized provider, such as nurses, child development expert, and doulas, which go beyond the typical scope of care provided by MCOs. That's one of the reasons. And these services are designed to address specific maternal and child health as well, as outlined in the bill, needs that require expertise not typically integrated into MCOs. And to Delegate Selega's question, the funding mechanism, and this fund helps get extra federal money, a chair described through Medicaid, doubling the resources for this program. And these approaches ensure the program support is statewide, and we have a healthy goal that are managed consistently, and rather than leaving it to individual MCOs, which might not have the same ability or interest to run these program equally. And the last sentence, these programs are part of public health approach aimed at addressing the systematic issues such as severe maternal morbidity, birth outcome, and other things that MCOs cannot do, and they don't have an interest. Thank you.
Delegate Riley. Thank you.
To thank Chair Bagnall for providing the information that she did. I did have questions in subcommittee, and I was one that voted no and requested additional information, which you did provide to me, so thank you. And then the additional information during this robust conversation and answering our questions, I do really appreciate it. Thank you very much.
And thank you. And I appreciate you asking the questions and making sure that we have the answers, right? And if we don't know, we get them, and especially the facts, right? So I want everyone on this committee, especially in subcommittee, that's to really ask those questions, right? I mean, that is really important. So thank you, Delegate Riley. Delegate Hill.
Madam Chair, and thank you. I just wanted to say one thing based on what Delegate Bandari says. It is my belief that when we do the upstream things, it saves us downstream cost. And the upstream things are often, although costly, much less expensive than what it costs us downstream. So if we have healthier pregnancies, healthier births, those children will tend to grow up healthier, better educated, more able to contribute as they become adults. And it solves so many of our other problems because we know, whether we're talking about behavioral health issues or social issues or other things, it all is rooted in a combination of where did you get your start and what were you burdened with from the beginning. So I think I'm so glad that the committee generally understands that we're not just talking about statistics and trying to look better than other states in our numbers, that we're actually talking about making things better for a brighter future for all Marylanders. And I just wanted to add that.
No, thank you. And I believe it's the answer for the question is that it stays in the fund, like Delegate Hill said. It's dedicated and approved by Commissioner for a specific purpose. So it has to stay there until we decide. So that is the answer. And thank you for the question. I appreciate it. Any other comments? All right. Seeing none, it was moved. Oh, there is Delegate Bagnall.
Thank you, Madam Chair, and thank you for the indulgence. I just wanted to say thank you to everyone for your questions and your comments. And I just wanted to contextualize a little bit because I'm very proud of the work of this committee. It's hard to see the overall impact of how important this funding is when you're looking at the individual programs. But what makes this so impressive and so meaningful for the state of Maryland is that each program addresses a specific need for a specific community. And it's looking at better maternal and child health outcomes from prenatal to 3 across our entire state. Home visiting services, our highest utilizers are Western Maryland, the Eastern Shore, followed by Washington suburban, Baltimore suburbs, and then Southern Maryland, because they looked at what does that community need and what programs make sense and leverage those dollars. The doula services are specific. They're primarily Baltimore, the Baltimore suburbs and the Washington suburbs, because they addressed some very real cultural competency issues around labor and delivery for our Black moms and babies. Centering pregnancy is looking at prenatal education so that moms are addressing self-care around being pregnant and all the things that maybe they don't have access to in a shared environment so they can be having those conversations with other moms. And Healthy Steps is again a group setting where you're talking to other parents about your babies 0 to 3 to make sure that those early childhood development steps are that you are getting training in how to do that. And of course, our moms dealing with opioid use disorder, managing that and making sure that we are delivering healthy babies in an environment where we are really challenged by the opioid crisis. We should be really proud of this work, and really proud that we were able to be innovative and work with the federal government to leverage these dollars. And so I would just ask that we vote to give the department the time to keep these programs moving forward.
And Delegate Bandari.
Yeah, to the subcommittee chair, I believe if I understood correctly, MCOs prioritize the resources differently based on their enrolled population and financial consideration, right? I think if we have a centralized funding and administration, it ensures equitable access across all the regions that they don't do. Is that correct?
That is correct. Thank you.
Okay. All right, so the bill, I want to say thank you for the robust discussion. It is always welcome here, okay? It's been moved and second. We have had a wonderful discussion. All those in favor say yes. Yes. Any opposition? Seeing none, the bill passes, is unanimous. And actually, this concludes the bill, this voting session, our first one. This was robust. Yes. Delegate Szeliga.
Thank you. I look forward to a report on how the 24 million, I mean, I appreciate what Delegate Bagnall said, but let's see some numbers on how many moms you helped.
Absolutely.
How many kids you helped. Let's make sure that we're holding people accountable.
Absolutely,
Thank you.
absolutely. And I know that they're listening, so for you guys that are listening, we want that report, okay? And share it with everyone, not just Delegate Shalega. Any other questions? All right, thank you so much. I want to say thank you to staff for a wonderful week and for all your work, and thank you for the committee for being so caring, and thank you, Erin, okay, for being available. You know, she's not only available here, but you guys, as you know, you call her on the phone, so do I, at 10 o'clock at night, 9 o'clock at night, on a Saturday, on a Sunday. And I want to thank all three of them for doing the work they do. I hope you have a blessed weekend and that you get to rest. And I look forward to seeing you all on Monday, God willing, okay? Thank you. Oh, no, wait, we have a briefing. We have a briefing, sorry. I apologize, but I do hope that we have a great weekend and that we get to rest after we do the briefing, okay? So what time is the briefing? 12:30, and it's now 12:11. There's some food in the back, so why don't you get some food and let's come back, and then we can be done quickly, okay? If people come back on time. Thank you so much. See you.